Welcome to Quad A Now, where we explore the world of patient safety, the impact of accreditation, and other topics relevant to outpatient healthcare facilities and dental practices. Join us as we explore diverse topics, share success stories, and navigate the challenges that define the pursuit of excellence in patient safety.
Welcome back to Quad A Now. In today's episode, we explore the crucial differences between private practices providing either physical, occupational, or speech therapy on the one hand, and Medicare-Deemed accredited outpatient physical therapy offices on the other. Joining us is Dr. Richard Hillyer, a distinguished Quad A board member for over 14 years and Vice President of Quad A's Accreditation Committee. Dr. Hillyer brings a wealth of experience in policy development, board oversight, and accreditation survey review to the discussion. With a background that includes a Bachelor of Science in Physical Therapy, an MBA, a Master of Science in Healthcare Administration, and a Doctor of Physical Therapy, his insights are invaluable. As a former Army combat medic and instructor, Dr. Hillyer's commitment to patient safety is deeply ingrained. His experience runs the entire spectrum from private practice and consulting to administration of therapy programs and hospital departments. He's a vocal advocate for accredited facilities, emphasizing the critical role of inspection processes like Quad A's for ensuring quality healthcare. Join us as we dive into this important conversation with Dr. Hillyer, exploring the benefits and perhaps some of the factors that many in private practice, or even in large organizations, may not have considered when designing their care and business models. Thank you for joining us today, Dr. Hillyer.
Thank you, Tom. It's a pleasure to be here.
Okay, so although you're on the board of Quad A and you serve on several committees, therapy services are really where your heart lies. So I wonder if you could just take us through your journey as a physical therapist and into organizational leadership and into this sort of oversight functions in the rehab world that you've taken throughout your career to kind of set the scene for us.
Yeah, thank you, Tom. It's been quite a while. Actually, having started as after combat medic school, a Army physical therapy specialist. I was an enlisted person in a program that is now physical therapist assistants. Got out, went to school on the GI Bill, became a physical therapist. I worked in nursing homes and then was recruited to run a small hospital department. And sort of as a one-horse practice, I was not only the clinician, but I had to take care of everything administrative, from payroll to hours planning to supply earning and all that. As time came along, organization I was with promoted me to its home office, where I was vice president for personnel, which included the recruiting function as well as everything else in personnel, from wage and hour to benefits, to the very beginnings of the non-discrimination issues. From there, I moved into my own private practice and hospital contracting. My own private practice was what they now call the PTIP, the physical therapist in private practice. It was very easy to do, and did that for several years, and then relocated to a place where I decided to become an OPT. Part of my work had been as an administrator of an OPT back in the very beginning, when everybody wanted to become an OPT, partly because the reimbursement was amazingly good for large organizations. Since then, I've had my own rehab agency on 2 occasions. I've been a manager and a system director in a large 5-hospital system with 245 employees and a $21 million real budget. Moved on from there, and I had done some home health. And my heart keeps coming back to the outpatient rehab agency. Rehab agency is a very convenient thing because the contract with the government is with the organization, whereas in a physical therapist in private practice, the supplier agreement through the Medicare administrative contractor is with the individual therapist.
Yeah, so that's That's critical, and I think that's the next point that I'd love to explore with you. But first, just to set the stage for perhaps therapy providers or service providers that may not be as familiar with the term OPT because it's sort of a defined term and it's a Medicare provider type. And many people out there practicing in speech and occupational therapy and physical therapy may not specifically know when we're talking about OPTs. What that means is Medicare's outpatient physical therapy program, but they also have sort of a slashed title, and it's also OSP, which is outpatient speech pathology services. So when either you or I are talking about an OPT, we're really including both of those. So what we're talking about collectively is physical therapy, speech therapy, and occupational therapy. And so for providers out there who might be listening, OPT is sort of a catch-all. The other sort of catch-alls that fall into that, those organizations, if I remember correctly, can be a clinic, a rehab agency, or a public health agency. Um, in my experience, we deal mainly with a rehab agency, which are private entities that work um, in those specialties and in those fields, provide those services. But the clinics can also meet those definitions if you're providing therapy services in a clinic as it's defined by the government, or public health agencies. So those words we throw around quite a bit and are somewhat interchangeable to us, but I think are unfamiliar to the people that don't live in the alphabet soup that is government regulation and healthcare oversight. So I just wanted to throw
Yeah.
that out there. But
Exactly.
yeah, and
Yeah.
as you said, at the heart of any conversation about how to provide therapy services effectively and efficiently is reimbursement. I mean, if you can't get paid, you can't keep the doors open, and that business model is important, especially Medicare reimbursement. So, before we get into rehab services very specifically, can you talk more about the difference between a healthcare provider and a healthcare supplier? Because again, I think particularly early career practitioners may not be thinking in the terms that the reimbursement model and the government oversight model works, and how they differentiate between providers as individuals and suppliers as entities.
Absolutely. Um, what we need to think of is going back to the roots. When Medicare first began, it was set up to provide for hospital charges and physician services. And that was, in the middle 1960s. That included eventually um, nursing homes. That included home health agencies. In time, certain laboratory services became added, and in time, physical therapy services, speech therapy services, and then they added OT services sometime later. The Part A providers of service are institutional, they're organizational. Contract, as I said, is with the organization. All those Part A activities have a dedicated full-time administrator, hospital administrator, nursing home administrator, home health administrator, rehab agency administrator. And we use that rehab agency, Medicare Certified Rehabilitation Agency, as that. And they are specifically providers as Medicare considers it. When a physician opens their doors or a physical therapist opens his doors, these days, or an occupational therapist or speech pathologist opens their doors, they can make an arrangement with the local Medicare administrative contractor, and they become a supplier of services to that Medicare administrative contractor. And that's where their contract is, and that's how they supply the Medicare world. When an organization becomes certified or accredited as a provider, it is the organization. And if a therapist leaves the organization still has a contract. In a what they nickname the physical therapists in private practice or occupational therapists in private practice, the P-tip or the slip, to use a terminology. In those, if a therapist leaves the group, that contract goes away. They can find ways to cluster together as a quote unquote group practice, which is more than one therapist. But that is comprised of people with individual supplier agreements with a Medicare administrative contractor who then reassign their benefits to the group. They file that the group becomes supplier. So it's a little bit more complicated. And the larger organizations who want to say no, we will, as an organization, participate with Medicare. Generally, they have moved on to being a provider. So the big difference between a provider is the organization, a supplier is the individual therapist. Hope that that's useful that way.
Yeah, I always think of it as a personal services contract versus sort of a contract between institutions or entities. And for most people who are listening, or in my experience, most people who are just getting into the working world as therapists, when I go to events either for APTA or AOTA or ASHA, most of the people who are just getting into the career, and even frankly, folks who are, much later stages of their career, have never really considered that. They just basically think about the dynamic of providing their provider number to Medicare and getting their reimbursement for their personal professional services. And they're not really, in my experience, thinking about the dynamics that go into what they're allowed to provide, how they can provide it, and how they get that reimbursement. It's essentially just, I do work and I get paid for it, which is, it's a fine model. But I think if you're thinking about scaling, or if you're thinking about being a business and looking for stability, even from an individual standpoint, rather than an employee of a large institution, it's at least bears some consideration if you can think things through, because we even see large, major, multi-state, national, regional companies that essentially operate as a huge group practice. And so Quad A has been involved in the rehab world since 2011. Your experience goes back much farther, but what I've experienced is that from individual providers who are just finishing school, to late career individuals, to complex corporate organizations, it seems to me that people gravitate toward that group practice, private practice model, where there's a lot of limitations, as you said. Even though the specific dollar amount of the reimbursement is the same, the operational and organizational impact is huge. So could you talk about some of the limitations from an operational aspect, from indirect cost standpoint, and why someone providing therapy services, either if they're specifically an OT, specifically a PT, a speech or audiologist, why might they consider kind of shifting their model, and even on an individual basis, becoming an institution and an OPT? What might they consider that they haven't so far?
Okay, that begs us to address part of that issue of provider versus supplier again. And I have in the past, if I set up a group of 15 therapists as a P-tip, and we are a therapy provider, we fill out a federal form to set up the business. There's a challenge which I have not heard being addressed yet, but that is a physical therapy group billing for occupational therapy services or speech pathology services. These are all valuable to the community, but I think that there is the potential for some expensive legal fees if you came around to somebody saying, you've been billing OT services and speech services as a physical therapist in private practice. And who knows where that could go. For that group, when you go multidisciplinary, I think the cleanest way to go is to be a Medicare certified outpatient rehabilitation agency. That would be through the states. If you become accredited, it's through you're a Medicare accredited outpatient rehabilitation agency. So it's a cleaner way to bill for multiple disciplines on that. There are several areas that are of concern when you're operating as a PTIP or an OTIP. One of the most popular ones, most controversial these days, has to do with issues of supervision. Since for a physical therapist in private practice, and I'll use that term generically, but it would include an occupational therapist in private practice occupational therapists have occupational therapy assistants. Physical therapists have a physical therapist assistant, which is dedicated to that individual, to the therapist. The challenge comes.
Speech pathology has the same dynamic as well.
Yes, but it's very rare places to find speech pathology assistants because they were in master's degrees and certificates of clinical competency well before the rest of us. They're some of the brightest people in healthcare. If I'm in a neighborhood and I want to send an assistant out to see grandmother in a 55 plus community, I may not do that and send them alone. The contract is with me or that therapist.
You're talking about when you're under a private practice.
Private practice.
Yeah, you can't send the assistant out unsupervised because the contract is an individual, as we said, personal services contract.
And even in the office, there are 3 levels of supervision, which is being debated everywhere from the National Association of Rehab Agencies to the 3 professional organizations. But personal supervision actually means I'm in the room with my licensed assistant. They may be providing treatment, and I must be there because legally and financially, it's me providing the service through their hands. So there's personal, but then there's direct supervision, which means I'm in the suite with them, not necessarily in the same room. And finally, there is general supervision, and the general supervision works pretty well. That is very much where the rehabilitation agency or the OPT functions, very similar to a hospital or a nursing home. So general supervision can be done by staying in contact. These days, that means by telecommunications. If I have a rehab agency, I can send my assistant to the home across town. Or if I'm in a assisted living environment, ALIL, I can send my assistant down the hall to see grandmom where she lives. When they step out the door into the hallway from the agency, they are in common ground and they're going to see grandmother. If I'm a PTIP, private practice, I may not do it that way. I must be either in the room or in the suite. That's a big issue for a lot of our rehabilitation agencies, of which we accredit in the neighborhood of 350 right now. So that's a big point.
So I want to clearly separate these because I know we've had this conversation before, and I know from my experience how big I think this topic is, and I think I know where you're going next. But so I think the number one, the very first issue about the dynamic shifting between the individual practice, the private practice, and the group practice is just starting from the use of extenders, right? If
Yes.
you're a therapist, whatever the licensing is, whether it's PT, OT, speech, and you want to utilize assistance in the most responsible way, becoming an institutional provider allows you to send those assistants out into the community, elsewhere in the building, elsewhere on the property. They really become an extension of your own licensed provider um, uh, reimbursement contract with Medicare, so that those assistants can bill for services without sort of any gray area, any debate, or any legal problems, in a way that they can't as an individual provider. So if you're talking about a major group practice, now all of a sudden your 10 providers can become 40 providers by the use of assistants. Or even if you're an individual, you can go from your own pair of hands to 3 or 5 sets of
Yes.
hands by the use of assistants, in a way that's really not as straightforward and not as clear cut when you're providing care as a private practice or a group practice.
Yes. We need to make sure that we don't in any way diminish the value and the skills of the licensed assistants. These folks have, at the minimum, an associate's degree, the same as 2-year RNs would have, that could be the director of nursing in a nursing home and things like that. Assistants are very competent and they can be done. In that rehab agency, you actually have the opportunity to use the assistants more clearly within the value that they can provide. That these are very good people, and yeah, we need to recognize that it's you have to be concerned about the issue of supervision when you're in the private practice mode. So that all works out. There's another issue that comes up, and that has to do with credentialing of therapists. Insurance companies don't want to have just anyone, even anyone with a license, treating patients and getting paid and running up their bill. The insurance companies want to know that you're qualified. They want to check your background. They want credentials. And in a private practice, every individual has to be credentialed with every insurance company with whom you do business. For CMS patients, if you're in a rehab agency, you've credentialed that individual one time. And if you have extension sites, you may send them as you see fit. And if that individual leaves, the company is still intact in its relationship with its customer, CMS. If you had a private practice and a therapist needs to miss time because of various family issues that can come up, you get back into issues of who's treating. If I own a private practice and I had to be out for 3 months with pneumonia, as did happen one time, then all the credentialing, I can't just bring someone in because the contract is with me. But I was a rehabilitation agency and I could just assign another therapist to go over there, and the company was in business.
Yeah, I think it's an interesting, and it's such an important point that, again, I think a lot of people, especially young, early in their career therapists, don't really consider a lot. Is one, if I have an absence, prolonged absence, I especially for the people that tend to work solo, they're probably not as concerned about staff turnover, but even from a personal standpoint, if I go on vacation, if I have a long absence to take care of my own ailing parent or something like that, I have to, one, transfer all my patients to some new person that has to go through the credentialing process. And also, I have to worry that I'm going to not have a patient when I come back to work, or that my patient load has going to have left me because they fell in love with that new provider. They think they're great, or they've just gotten in the habit, or it's more convenient. Whereas if you're an institution, as you said, the contract is with the institution, and your team can change over, your people can switch over,
Yeah.
you can take a vacation, someone else can swap in. We've credentialed them as part of the institution. So we still have a small credentialing component, but it's not the same as having to navigate a new contract with Medicare. But also, when you return from that extended absence, there's still a patient population that collectively the institution is serving. So even if the individuals swap around, you're still covering and still receiving patients and still dealing with patients. And you don't have to worry about having lost them to some other provider. For a big institution, certainly, I think turnover is a big deal. Long-term absence is a big deal. I can't imagine the paper shuffle of credentialing and contracting that all of these large sports medicine and institutions and these huge providers that are multi-state that are popping up everywhere seemingly. I can't imagine the paper shuffle that they go through as each individual therapist takes a vacation, goes out, and they have to get a new person credentialed or a new person approved as the care provider for that patient. I don't know how the big companies, in Chicago, it's Accelerated, it's ATI. There's a whole bunch of other large commercial entities that do this type of work. And I can't even imagine the amount of time and financial resources and human resources they have to devote to keeping people individually assigned as providers and providing that care under their contracts with Medicare and other insurers.
Yes, I've experienced that as an issue myself. Earlier in my career, I wanted to take a series of orthopedic physical therapy courses. And the first course that I took was a 9-day course. And I was in South Texas. I had to go to Dallas. I had to hire someone to come in and treat my patients and take care of things in my office. I had to make sure that they were acceptable with all the payors that we would be dealing with while I was out there improving my skills so that I could serve that particular community better. It's legitimate. I had a therapist who worked with me who was young, started a family, had to miss some time. Same thing. You have to find a way to replace that person with all the insurers. The rehab agency is an organization. It's like someone working for a hospital or a nursing home. And that arrangement is there. Incidentally, there is also an issue that comes up not just beyond the credentialing of PTs, but there are some economic barriers, if you will, that some of the insurers have used over time. And that is, an insurance company may limit the number of providers on its panel. If every therapist wants to see 10 patients, the insurance company is going to be spending a lot more money if they have 100 therapists than if they only have 50. I often, when I'm doing surveys, and I think I quit counting after about 150 agencies, not to mention extension sites. And I ask, why would you want to be a outpatient rehabilitation agency rather than just be a physical therapist in private practice? And the most stunning comment was in one of my last surveys. A therapist who's been a rehab agency in her own private practice with 2 or 3 staff for 25 years. And she said, well, some insurers are not accepting new people. I could not transfer out of being an OPT rehab agency into being a PTIP because, the state in which we are, the Blue Cross Blue Shield is the major insurer, and they're the Medicare and administrative contractor. And basically, they say they're not accepting new people. So thank you very much, but no. And this person said, so she stays as a rehab agency because she doesn't have the option to do anything less. Furthermore, she said she's in an office park that is full of physicians, other physical therapy practices, and she feels that she's a step above because she meets standards. Basically, it doesn't have standards for less than a rehab agency. So she provides extra care, but she says people come in here and they know that we get inspected. They get annual inspections by fire marshals. They do an annual self-survey to run through our credentials, and then they get our 3-year survey.
That's interesting. I wasn't quite aware of the issue with some of the payers not enrolling new private practices, because I think,
Right.
again, as you said, if they want to limit it to 100 or 1,000 or whatever the number is, private practices or private individuals that they contract with, we know of rehab agencies, of OPTs that have 100+ therapists or therapy providers, whether it's OT, PT, or speech, on their roster, right? But it's still one
Yes.
contract. It's one contract with Medicare. It's one contract with other payers. And having a staff of that size allows them to scale without having to worry about filling that roster up and being
Yes.
denied by the Medicare
Yes.
administrative contractor for that area.
Right.
That's fascinating. And so now you've got, I can use extenders. I have extension sites, and I don't have to credential people, worry about losing my patients when I need to take a leave of absence. And by the way, I also reduce the impediment or the barrier to being able to provide care because I'm not filling up the roster. The other one that
Right.
strikes me, and I wonder if you'd talk about this a little bit, because you touched on it a little bit when you talked about perhaps a physical therapist in private practice, maybe providing some OT services and charging for it, and that being, a touchy subject to say the least. What I'm struck by, and again, this isn't limited to large organizations; it's individuals. I know speech therapists, I know speech pathologists who work with young children, and a lot of their work is out of the back of their car. They drive around, they go into the home, and they do exercises with the children, or they go into schools, or whatever the case may be, and they're providing care under their own license and with a personal um, relationship with Medicare as an individual provider, as an individual licensee. And then in my community, there's a lot of 55 plus buildings going up, and they need different services, maybe some more
Yes.
PT services, maybe more OT services. And I'm always struck by the fact that those dynamics lead to the need in our community for diverse services. And while you're a physical therapist providing care in our private practice model, may only provide physical therapy services. And if you're a speech pathologist, you may only provide speech therapy services. But if an enterprising speech therapist who's working with young children and an enterprising physical therapist who's working with an aged population and needs more infrastructure were to team up, they could essentially cover each other's backsides by saying, I'll handle the senior population, you handle the young population, and perhaps we can cover each other a little bit as the demographics in our neighborhood shift. And I need a big building with a lot of equipment, and you're just, working out of the back of your car. So we'll make sure you have an area in the building, and we can provide both of these service lines, and we can start to hire assistants, and we can start to go into the home, and we could use all of these dynamics together to provide more diverse services to have a better economic model rather than sort of hanging out your shingle and doing your work all on your lonesome. I wonder if you'd talk a little bit about that.
Yes. When we first started, I'd say early on, when we were beginning to accredit rehabilitation agency, outpatient physical therapy outpatient speech. I surveyed in extremely rural, low socioeconomic areas several agencies where a speech pathologist and an occupational therapist had collaborated to start a clinic to take care of special needs children and the pediatric care. And that group in many cases was under Medicaid, and they were not able to serve the Medicaid population unless they were recognized as as an outpatient physical therapy, speech therapy, rehabilitation agency. And they were able to practice together and serve a very important part of the community. Many of the problems in pediatrics was that children were staying with grandmother all day and maybe couldn't get transportation, would miss appointments. And that particular group said, okay, we can find a way to go out. Actually, 2 or 3 of the groups had operated minivans with a driver and a chaperone to go out and pick up the children and bring them in, which they couldn't do as a private, as a PTIP. Not that they didn't have wonderful skills, not that they didn't provide wonderful services to the community, but procedurally, they were not, it was that argument of, yes, you can, but no, you may not, to get into the Medicaid world. So we did a lot of that. And then that probability came along where they added on a therapist and started to serve in the term CCRC, continuing care retirement community, which is the assisted living, independent living, 55 plus, that they could see people in their homes as outpatients there. And in that same community, they may have also had a nursing home, and there may have been home health people around too. So the agency was able to serve that particular population in a more effective, efficient way, and at least in part of it in a way that they would not have been able to do, because in that state you couldn't do Medicare, you couldn't do Medicaid unless you were a Medicare agency. Additionally, there's at least one state where we have, I'll say, a large number of outpatient rehabilitation agencies. And again, they're agencies, whether they are being accredited, followed by the State Department of Health or by us is a moot point. They're agencies. And in that particular state, I think the Blue Cross Blue Shield provider would not do business with a private practice therapist organization unless it was certified as meeting these higher standards to be a rehabilitation agency. And I've been aware of that for 30 or 40 years. So
you mentioned that a couple of times, including the person who was sort of stopped from being on the roster because they didn't want any more individuals, licensees. So,
right.
Quad A, the process of accreditation, as a deeming authority allows us to recommend for Medicare approval an OPT, OSP facility, an agency that is able to contract in a different way. And it's that transition between provider and supplier that you spoke about. But it is a little different than simply filing for reimbursement and doing a paper shuffle. As a practitioner, it's a little bit more robust. And as you mentioned, that one therapist really saw the value in that by saying there's a lot more to this than just saying I'm a therapist. It didn't change their clinical expertise, but it changes the care model in a way that therapist saw as beneficial. So could you talk us through the major differences and what goes through the process and what that really says about the care that's provided in OPT versus a private practice or a group practice model?
Certainly. Yes, there are many people in the rehabilitation agency world who feel that it gives them product differentiation to say that they, in a sense, meet standards. They're fine people who are in private practices. But the rehabilitation agency actually has to have demonstrably met standards on a regular basis. When I need to go back and clarify with you on that, people coming along and saying, what is the difference and what is the process whereby anyone, whether they're brand new or they're transitioning from the PTIP, OTIP model, SLIP model, to go up to the rehab agency. Initially, process can vary, and if nothing else, an accreditation organization is a process organization. The individual contacts in our state, they contact the Medicare administrative contractor, and they submit a certain federal form, 855A, for a Part A provider. And that is submitted to that organization, the MAC, Medicare Administrative Contractor, or MAC. And those folks then, if they like what they see, they can deny it. But if they accept what they see, they can send it to the Department of Health. And because of the number of growing providers, almost every state has said, well, you'll be a level 4, which means we probably won't get to you for an initial survey. Then that comes to the desk at the accreditation organization. And again, forms are checked, standards are checked, employees are run through background checks. They are compared to the federal list of parties which are not eligible to participate in Medicare to make sure that they're clean. So we get background checks on every one of that agency's employees, and then paperwork gets put together, a clean package is put together, a survey is scheduled with a trained surveyor. In our case, it's with peer surveyors. We don't send a non-therapist to survey a therapy facility. So we send them. A survey comes. It's very simple. There are standards that have been reduced to almost a binary. For example, there is a fire extinguisher in a convenient place. Is there or is there not? And we check off, say, yes, there is. Move on to the next topic. Generally, the statement is, may I see it, please, for everything we see. And in that survey, there's a review of the governing body, the actual physical premises. There is observation of patient treatment going on by the staff. There is a review of all of the policy and procedure manuals that address the certain standards, including the ones that came up in the last 5 years or so on emergency preparedness programs. And after that examination, any deficiencies are noted, it's communicated, and a report is sent into the office. In 10 days, the office responds back and says, you had this deficiency or that deficiency, please send us a plan of correction, which is done. And when that entire set of standards are met, 100% of the standards get met in an accredited facility, then packages submitted off to, and from there is, you were director of accreditation when I first started doing things. But from there, it either goes to Medicare regional office and then to the Medicare central office. And when that's approved, then you get a certificate and you get the number and you are one. Incidentally, you might be better to address the issue of when questions come up by the agencies. I believe that when they deal with us, it goes to the CMS central office rather than regionals.
Yeah, that's true. So, I think what you said is really important, and tying it back to those licensees that you talk to, if you've filed as an individual licensee for private practice or group practice, it really is a paper shuffle to give you documentation. And then you're providing your services and you're kind of open for business. Whereas if you're an OPT, you can really differentiate your practice from those private practices and group practices by saying, yeah, we've gone through this comprehensive process to make sure that we have appropriate equipment, appropriate maintenance schedules for our equipment and calibrations, and that we have emergency planning and governance at a higher level that isn't so onerous that it becomes a hospital, but presents to patients enough organizational development that to give more confidence that they're being treated appropriately, that they're being treated well, and that there's safety protocols in place to make sure that, God forbid, if something does go wrong, you and your staff are prepared to handle that, and that thought has gone into these decisions, and it's not as much just whatever natural response you might have at the time, because now there's
Yes.
planning and there's drilling and there's these other things, and
Sure.
I think that's really important. And to your point, compliance can be a challenge. I think it can be a challenge in a private practice, as much as it can be in a group practice, as much as it can be in an organization. One of the great things that is of value, I think, through this process is that we have, as an accrediting agency, a different relationship with Medicare. It's sort of we're not really a partner because we're not really acting as their agent, but we've gotten approval for them, and we have a different nature of conversation with Medicare than the facilities do, because Medicare is not reimbursing us, and it's not a question of, are we going to be reimbursed? Is Medicare going to come and look at this issue that I've brought to them, and kind of is some inspector going to come in and crack down on me because I've highlighted my own weakness? One of the great benefits is that when facilities bring us questions about compliance or struggles they have with compliance, especially as novel approaches and novel products come online, we're able to de-identify that conversation and have it in a more collaborative way with Medicare's central office, so that we get a direct line to the decision makers to say, is this within the spirit of the regulation and the law? Is this novel approach, is it consistent with what we want to be achieving for patient safety, for the beneficiaries? Because obviously technology and practice moves faster than legislation and regulation. So once we get clarification on that, we can go back to the facility and they can be confident that that conversation occurred without sort of bringing a level of focus and scrutiny to them that might make them less comfortable.
Yes. That has also happened in the consulting world. We've had multiple uh, practice consultants who advise on compliance uh, contact us to ask questions such as, uh, the organization that owns the agency also owns the larger building of the independent living and assisted living. Can the administrator of the ALIL also be administrator of the rehab agency? And it's possible to say, tell you what, we have people who can contact CMS and can come back and say, okay, to answer your client's question, here's what the standard says. You must have your own dedicated administrator. And the consultant is able to speak reliably and with confidence to their client. And we've been able to identify the standard and what the state operation manual calls for to the letter of the law, because we don't improvise around or wiggle.
Absolutely. So I think, for me, the takeaway from this conversation is always that whether you're an individual therapy provider, whether you're part of a large group practice, or whether you are in an OPT as it stands now, there are a lot more inputs into the decision to go from a provider to a supplier than simply what is the black and white reimbursement rate for this intervention, right? You have service diversity, you have extenders, you have administrative burden, you have all of these things that play into it that really affect in a different way an individual, because if you partner up with somebody in a different service line, you can kind of cover your backside than it does for a large multi-state agency that might be a group practice, because maybe you can save hundreds of thousands of dollars a year in administrative burden from not having to constantly be shuffling through your credentialed licensees with Medicare. But there's more that goes into the decision than simply what's the reimbursement rate for this patient intervention. And I think if there's any takeaway for me, for listeners, that would be it from this talk. Is there anything else that you think someone should leave listening to this, noodling over before we wrap up?
Yeah, I would say that most therapists who I have known are proud of what they can do with their hands. They're proud of the service they provide to their patients. They're proud of their safety, their competence. They're proud that they can serve that community. And by community, I mean the political jurisdiction, not necessarily the little retirement neighborhood. And they're proud of that. And it's very gratifying to be able to be part of something so that those people can also say, and as a mature, high-level functioning therapist, we meet a higher level, we meet a higher standard. And that lets them focus on everything about what they're doing is about patient safety. The issues of signage for emergency, the issues of equipment being inspected for patient safety. I think a lot of people feel like it moves them toward a higher level of functioning, as well as a broader level to be able to have their organization function. So yes, it's been at this point, 15 and a half years since that first surveyor course. And as I always tell people, it's an honor to work with Quad A. And I am proud every time I go see and visit with administrators and therapists on site in their working facility, in their clinics, taking care of their public. And really, when it boils down to it, helping people get better and taking care of them at a high level, to me, is really what it's all about.
That wraps up our discussion on the differences between private and group therapy practices and accredited outpatient physical therapy services. A big thank you to Dr. Richard Hillyer for sharing his expertise and insights with us today. Dr. Hillyer's emphasis on patient safety and the importance of Quad A accreditation highlights the vital role these standards play in ensuring quality care for communities across the country. We hope you found this episode informative and enlightening. Join us next time on Quad A Now for more discussions on healthcare accreditation, patient safety, and industry insights. Remember to subscribe for future episodes, and until next time, stay safe and stay healthy. Thank you for listening.
That's a wrap on another enlightening episode of Quad A Now, a global accreditation podcast. Stay tuned for more captivating discussions with leaders who are shaping the landscape of quality and patient safety. Remember, patients first, always.